All right. David Etzioni is here from Mayo, Arizona. He's going to talk to us about colorectal quality. What does it mean, and how do we measure it?
Thank you, Peter. It's nice to be back in the old stomping grounds. Thanks, Kyle. Thanks, Dr. Lee, for inviting me. I'm going to change the topic, the type of topic a little bit, and move away from a clinical topic to something that I think touches all of us in surgery or non-surgical fields about how what we do is measured. And try to make it specific to colorectal, but I think that you'll find this applies to all surgical fields and like I said, also potentially to non-surgical areas. I have no disclosures, but the measurement of quality I think is especially poignant for colon rectal surgeons in surgery. Surgical care in general encompasses 27% of domestic healthcare expenditures. There are 260,000 colorectal resections per year performed in the US, and the complication rate in these operations is approximately 30%. So colorectal surgeons and surgeries are responsible for about 25% of the total burden of surgical complications. So this is the right group to hear a talk about how the quality of care, what we do, is measured. Now, this person, does anybody here know who this is? Phil? Codman, right. So this is Ernest Amory Codman. And Dave Hoyt, the executive director of the ACS, is a big fan of Ernest Codman. He's a fascinating figure. He died about 103 years ago. They had a 100-year anniversary of his life recently. And this statement is bandied around a lot, especially at the American College of Surgeons level. We must formulate some method of hospital report showing as nearly as possible what are the results of the treatment obtained at different institutions. It's a very powerful statement. This came at a time where there really was no such thing as outcomes reporting, outcomes monitoring. Ernest Codman spent most of his career at Harvard. He was a Harvard undergrad, Harvard medical student. He was a Harvard-trained surgeon. I went to medical school at UPenn. We used to call that Preparation H. But he was really a trailblazer. And what he did was he implemented this idea that we should be responsible for the outcomes that our patients achieve. And we take that as intuitive now, but it really wasn't then. And he was on staff at MGH, and at one point, the senior surgeon at MGH, the chair of the department, retired, and Ernest Codman, who was relatively low down on the ladder, he decided that he was the only person who was suitable for that job, so he actually quit, and he reapplied to be the chief of service there. At that point in time, the only way in which you were advanced is if somebody above you either died or retired, so they laughed him off, and he actually left the marbled corridors of MGH, and he started his own hospital basically in the basement of his house. Not too many people do that anymore. But what does his vision look like now in 2017? Have you guys seen this yet, Doctors Cologne and Lee? So